Good morning, everyone. Despite so much of advances in critical care medicine and medicine, still today, sepsis is the leading cause of morbidity, mortality all over the world. Ladies and gentlemen, I am Dr. Zakir Hussain. Today, we are going to discuss about the latest 2026 surviving sepsis guidelines in adults. As you all know, sepsis is a major global health emergency with estimated 49 million cases annually and 11 million deaths occurs annually. So in hospital, sepsis mortality is roughly around 30%, and which increases to more than 40% for septic shock. It increases with the age, the risk factors increase with the age and comorbidities, and especially with the immunosuppressive patients. Among all the infections, respiratory infections are the most common, and pneumonia is the most leading cause of sepsis all over the world, followed by GI and UTIs. Sepsis is still defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock is defined as severe form of sepsis, which is characterized by the circulatory, cellular, or metabolic abnormalities, which require vasopressors to maintain the MAP of more than 65 and elevated lactate levels of more than 2, despite adequate fluid resuscitation. The surviving sepsis guidelines were by the group, both Society of Critical Care Medicine and European Society of Critical Care Medicine. They this time defined sepsis. They introduced new terminology this time with the definite sepsis, probable sepsis, and possible sepsis, and unlikely sepsis. These four terminologies were used this time. And we are going to discuss about 129 statements that were given in 2026 guidelines. And the first one is regarding for hospitals and healthcare systems, they strongly recommend using a performance improvement program for sepsis, which includes sepsis screening for elderly patients. And they implemented this new guideline this time for hospitals and healthcare systems to suggest using a code sepsis or sepsis huddle protocol over not using such a protocol. So code sepsis is similar to the code blue kind of thing, which contains multidisciplinary team. Whenever there's a sepsis screen is positive, then this team will gather at the bedside of the patient and they discuss about speeding up the process of sepsis diagnosis and treatment for the patients. And the new finding this time, they given the statement of any critical ill patients who are on the route to the hospitals in ambulance or air ambulance, they should use they strongly suggest use the standard sepsis screening tool in the ambulance itself. And for hospitals also, they say all the critical care patients in hospitals should use the news is that commonly we use in all our wards, national early warning signs or SIRS over start using on QSOFA. QSOFA has sensitivity only 23% compared to the national early warning scores. So that is the reason QSOFA is not used nowadays, as it misses 77% of sepsis cases. This is how this national early warning scoring system looks like. It contains few parameters. One is a respiratory rate to see for tachypnea or not. And there are two types of saturation. One is for hypoxic failure and second saturation is for hypercapnic CO2 retainer patients. There you should be using oxygen judiciously. And requirement of oxygen or not, and fluctuation in the blood pressures and pulse and conscious score ACVPU. This is also important. Based on the score, anybody with the red color here, they should be very cautious. And based on the score less than 4, they can be safely monitored in the ward. Any patient with a score of 5, 6, 7, they should be immediately informed to the med team or medical emergency team so that they can shift the patient to the high dependency unit or ICUs. And as you all know, sepsis and septic shock are the medical emergencies, and treatment and resuscitation should begin immediately. And this time, they clearly mentioned that sepsis is a clinical diagnosis, and it should not be ruled in or ruled out using a single biomarker. Like if just CRP is high, don't think there's just a sepsis. There should be multifactorial, even the diagnostic, laboratory, and radiologic diagnostic and clinical features all should be combined. The common biomarkers that they use in sepsis are lactate, procalcitonin, and CRP. And they strongly recommend this time for all adults with possible or probable or definite sepsis or septic shock. They should collect blood cultures prior to giving the antibiotics. And for all the patients with sepsis, they strongly suggest to measure blood lactate levels. And for any patient with septic shock, the guidelines clearly suggest administering at least 30 ml per kg of body weight crystalloid fluid in first 3 hours. The doctor should be carefully watching patients. Each patient is individualized for the treatment, depends on their age, depends on their comorbidities like heart failure or renal failures. You should be watching for under resuscitation and over resuscitation. There should not be any fluid overload for those patients. And the guidelines also suggest weight-based fluid volumes. If suppose somebody is 70 kilos, you have to give in first 3 hours up to 2 liters of volume crystalloids. And again, they mentioned that if any patient is morbidly obese, you should take ideal body weight, not the actual body weight. Unless, or else you will be ending up with flooding this patient with excessive fluid. And patient with sepsis-induced hypotension or septic shock, they suggest first initial IV crystalloid bolus. If there's not improving, early initiation of vasopressors is advised. And patient with sepsis, septic shock, the guidelines suggest using vasopressors peripherally also. Previously, the guidelines were to use through central line or EJV, but nowadays they clearly mentioned instead of waiting for central line to be placed, instead of delaying those process, just try to start the noradrenaline peripheral through peripheral line. Once you get a central line by your doctors, then you can start the vasopressor in the central line. This time they aim for lower maps to prevent unnecessary side effects from using excessive vasopressor. The guidelines clearly mention for any patient with septic shock, there's a strong recommendation to maintain maps around 65 plus or minus 5. So target should be 60 to 70. The lower maps are better tolerable for the patients than aiming for higher maps leading to unnecessary side effects. This comes from this trial, 65 trial and sepsis spam trial. There they clearly mentioned this time that for elderly patient with 65 years and older, the initial map target should be only 60 to 65 mHg over aiming for higher maps. The higher use of vasopressors are leading to unnecessary side effects like arrhythmias and also peripheral vasoconstrictive and ischemic side effects by using high dose of vasopressors. So lower maps are sufficient with these new guidelines. I know nephrologists don't like these lower maps because of the poor perfusion to the kidneys, but the guidelines and the studies clearly suggest that even with the lower maps also, the kidneys perfusion is good in this. And any patient with sepsis and septic shock who require ICU admission, they should be admitted immediately as soon as possible. Let's discuss about antibiotics. This time the guidelines emphasize more on antibiotic stewardship and early initiation of antibiotic and unnecessary misuse of antibiotics. So for the patient, any patient with septic shock, either it's a probable septic shock or possible septic shock or definite septic shock, don't delay giving antibiotics. Give antibiotic within 1 hour of your diagnosis. Collect the blood culture faster and give antibiotics early. There are strong recommendations. Even patient without shock also, without septic shock, if there is a definitive sepsis, the guidelines clearly mention giving antibiotics within 1 hour of your diagnosis. Each hour delay in antibiotics will cause unnecessary worsening of mortality. They say guidelines 10% increase in mortality by each hour delay in antibiotics. And for patients with possible sepsis, the guidelines clearly suggest you can wait up to 3 hours. Meanwhile, evaluate properly for the patient with imaging and laboratory and all those things to rule out sepsis. Once sepsis is confirmed, you can wait up to 3 hours for patient with possible sepsis. Whereas for definitive sepsis and septic shock, immediately within 1 hour, you have to give antibiotics. And for patient with unlikely sepsis, there is no chances of sepsis. For these, there are less chance of sepsis. You can still wait antibiotics, no need to give antibiotics, but have a close monitor of these patients. In case any clinical worsening, maybe you have to rethink again. And for countries with a highly populated, with a high traffic countries, there If patient is in ambulance, when it takes more than 1 hour for them to reach to the hospitals, the guidelines suggest giving antibiotic directly in the ambulance itself instead of delaying antibiotics in case of confirmative sepsis and septic shock, which is evaluated by the sepsis screening in the ambulance. The paramedic should discuss with the concerned doctors and then start broad spectrum antibiotics. And this is very important guidelines. They suggest this time that for patient initiation of antibiotics, there is no role of procalcitonin. Only clinical evaluation is sufficient to initiate antibiotics. So procal and clinical evaluation is not necessary. And for patients with sepsis and septic shock, if there is any source of infection is found with anatomical sources, first we have to address the source of infection. This is very important. Once there is a confirmation of source of infection, like infected central line or gangrenous fruit or significant cellulitis, the source control is early this time. Within 6 hours of the diagnosis, you should do source control compared to 12 hours in 2021 guidelines. So they said early source control has better improvement in clinical condition. For patient with multi-drug resistant bacteria, they suggest when somebody is having high risk of infection, they suggest using empirical antimicrobial therapy with containing this coverage. Whereas somebody is having low risk of infection, they suggest not to use unnecessary, very broad spectrum antibiotics. And same thing goes with anaerobic coverage also. Most of the antibiotics that we use has very broad spectrum coverage like carbapenems and piperacillin tazobactam that has unnecessary we use for patients where it has anaerobic coverage also. When the patient doesn't need anaerobic coverage, just go with cephalosporin or third generation cephalosporin that are sufficient. For ESBL and other things, there you need carbapenems or piperacillin tazobactam, you have to use it, or else try to avoid when there is no necessary for using anaerobic coverage, because that will unnecessarily kill good microbiome that is available in your gut and oral cavity. And patients who require anaerobic coverage, like patients with intra-abdominal sepsis or aspiration pneumonia or necrotizing fasciitis, these patients, you should use anaerobic coverage with broad spectrum antibiotics and also metronidazole and clindamycin. And they suggest this time to go for rapid diagnostic testing tools like a PCR for early diagnosis of the pathogen. And this is the important guidelines that they given strong recommendation compared to conditional recommendation last 2021. As you all know, beta lactams are time-dependent antibiotics. This should be given over prolonged infusion than giving the bolus infusions. In the emergency, the first dose of antibiotics should be always bolus. Bolus means it should be given over half an hour. Don't give first dose of antibiotic in the emergency room over 1 hour. First dose should be given in first 5-10 minutes, observe for any side effects or allergic reaction from the antibiotic. If nothing is there, within half an hour, finish off antibiotic. This guideline, this is meta-analysis of so many 17 studies that has proven that that has favored in the forest graph. You can see all prolonged infusion has favored decrease in mortality compared to intermediate boluses. And this time they suggested going for trough levels or therapeutic antimicrobial drug monitoring for certain drugs, and also depends on the availability of these trough levels. If the turnaround time is more than 48 hours, there is not much role of doing that in that facility. When there is availability in certain class of drug like vancomycin, where is the therapeutic range is very narrow, there you have to check for trough levels for the antibiotics. And the guidelines clearly mentioned for patients with sepsis and septic shock with unconfirmed infection, clinicians should continuously re-evaluate patient, search for alternate diagnosis, and discontinue empiric antimicrobial therapy if alternate diagnosis confirmed. And this time they have more emphasis on antibiotic stewardship. So they said de-escalation. When patient with sepsis and septic shock, they strongly recommend to de-escalate antimicrobial therapy. When you get the culture reports, just narrow down the antibiotics. Suppose you started on meropenem. When it is a non-pseudomonal bacteria, then you can just de-escalate to simple ertapenem or to go with simple third generation cephalosporins. So de-escalation is the key this time. And same thing goes with somebody with the cultures are sterile. Try to de-escalate as soon as possible antibiotics. And this time they have given clear guidelines about the antifungal coverage. In previous guidelines, they recommend any patient with sepsis and septic shock, they suggested to start empirical antifungal therapy in certain risk candidates. Whereas this time they clearly mentioned not to start antifungal therapy for patient with septic shock. Having said that, they still mentioned in the remark, in certain cases, like in post chemotherapy immunosuppressive candidates or patients who have prolonged hospital stay with prolonged use of antibiotics, these patients you should use judiciously. Whenever new onset of sepsis or septic shock in the hospital, you have to think about starting antifungal therapy. That's to echinocandins. Fluconazole doesn't have any role in septic shock or sepsis. And this time they clearly mentioned not to use any biomarkers, same like procalcitonin in fungal thing. No need to do biomarkers to initiate or to discontinue antifungal therapy. There's no role of this then. And again, I want to repeat this slide again. For bacterial infection, you should use clinical judgment alone to start antibiotic. Whereas for discontinuing and for de-escalating antibiotics, especially when you adequate source control done and optimal duration of antibiotics were given, then you have to decide for de-escalation. There the role of procalcitonin and clinical evaluation is there for discontinuing or stopping or de-escalating antibiotics. So you should use procalcitonin judiciously. And regarding antimicrobial therapy, as per the BALANCE trial, which was a recent one, which has shown that among the hospital patient with bacteremia, with bloodstream infections, the 7 days duration of antibiotics is non-inferior to giving 14 days of prolonged longer duration of antibiotic. So we can stop antibiotics early. I know a lot of physicians will not dare to do this when there is a patient is improving, but still the guidelines clearly mentioned there is a definitely non-inferiority to use over long-term antibiotics, which will cause unnecessary complications like Clostridium difficile infections. And this time they have come up with the digestive SG digestive decontamination program, where similar to like we give mouth care for the patient on ventilator, but the guidelines mentioned in ventilated patients with septic shock or sepsis, where there is a low prevalence of antimicrobial resistance in the ICU, they should use this kind of digestive tract decontamination to prevent hospital-acquired pneumonia or ventilator-associated pneumonias. Let's discuss about hemodynamic management and fluid resuscitation. So for patients with septic shock, the guidelines clearly suggest using either invasive or non-invasive blood pressure monitoring. These are because of the low resource countries, they don't have proper arterial line monitoring and all those things. But they clearly mention in case somebody is having requirement for high dose of vasopressors or multiple vasopressors, or patients on ventilator needing frequent ABGs, you have to think about starting arterial line invasive blood pressure monitoring for these patients. And regarding the fluid type, as we all know, crystalloid versus colloids, there were so many debates and so many studies, landmark studies like CHEST and SUCCESS trial, and even the recent crystal trial also proven that only crystal are the first line of choice for fluid resuscitations than colloids. Colloids like albumin, starch, or gelatin, these are not advised because they have unnecessary renal injuries and kidney failures with high cost for these medicines. And regarding the fluid, they clearly mentioned using balanced crystalloid over normal saline. As you see here, so if you give resuscitation with normal saline, almost 2 liters of normal saline, there is a high chance of causing non-anaerobic metabolic acidosis. But clearly they mention this balanced crystalloid is all RL and plasmolite. These things will have hypotonicity, which may further worsen cerebral edema in traumatic brain injury. So they clearly mentioned here that patient with sepsis with traumatic brain injury, you should use only normal saline, not ringer lactate, because they increase the cerebral edema. There are so many studies, head-on studies for crystalloid versus normal saline, but there is no mortality benefits or no worsening in kidney injuries. Maybe in the next guidelines, they may think about adding saline also. Regarding the fluid types, we always have this confusion, crystalloid alone versus adding crystalloid plus albumin. For resuscitation, the albumin should be used only 5%, whereas in certain cases, where because the volume, you don't want to give more, there you can still use, already patient is overloaded, you can still use albumin for septic shock or for increasing the volume. And also one of the remark they mentioned that patients with the traumatic brain injury, you should never use albumin as it will increase the cerebral edema. Regarding the fluid type, the colloids are no for resuscitation. Even the starches are not advised. And same thing goes gelofuscin. These gelatin substances, these are also not advised in any fluid resuscitation. And for patient with septic shock who has already received 30 ml per kg of fluid, still there is a hypoperfusion signs with a higher lactate, we suggest using liberal or restrictive fluid strategy based on the individualized patients. Depends on his age, depends on his heart status, cardiac status, and renal status. We should titrate your fluids. And while giving fluid resuscitation, you should always think about dynamic measures like passive leg raising. We should elevate the legs and give the fluid elevate leg for 2 to 3 minutes and see there is an increase in MAP or increase in the blood pressure. That means they are fluid responsive. Then you can give excessive fluid for these patients. There's a stroke volume variation, pulse pressure variation. These are the dynamic measures they suggested using for guiding for excessive fluid resuscitation. The guidelines clearly mentioned about going for serial lactate management to assess for resuscitation. And this time they added this capillary refill, like we used to use in pediatric patients or neonates. The guidelines clearly suggest using capillary refill time to guide resuscitation as an adjuvant to other measures of perfusions. It should be measured every 30 minutes till the blood pressure stabilizes. And adding vasopressors, the guidelines clearly mentioned that starting noradrenaline as the first choice compared to the dopamine, which is more arrhythmogenic. And other drugs, the first line of choice for any shock or any septic shock is noradrenaline. I want you people to understand vasopressors and inotropes. Don't confuse between vasopressors and inotropes. Vasopressors are the drugs that will cause vasoconstriction to increase the blood pressures, whereas inotropes are the drugs that increase the cardiac contractibility to increase the blood pressure. Vasopressin and noradrenaline, these are vasopressors. Only dobutamine is the inotrope. The guidelines clearly suggest noradrenaline as the first line over vasopressin and angiotensin too. And also they mentioned first vasopressor is noradrenaline. Second, if persistent hypotension and still requiring higher dose of norad, then add vasopressin. And still after adding vasopressin, still you see that there is a still hypotension, then you have to think about adding epinephrine as the third drug of choice. For patient with septic shock with cardiac dysfunction, the guidelines suggest adding either norepinephrine or epinephrine this time as the first line vasopressors. Norepinephrine in patient who is having tachycardia, epinephrine for patient who is having bradycardia is the first line choice of vasopressor. And they rejected terlipressin as a vasopressor, and methylene blue has some benefits, but this time they clearly mentioned there is no role of adding methylene blue as a vasopressors. For patients with septic shock with cardiac dysfunction, the guidelines recommend to use inotropes over not using inotropes. And in inotropes, they mentioned clearly adding dobutamine to the norepinephrine is the best choice. And regarding the levosimendan, previously we used to use this one, but the guidelines suggest, and as recent trials like Leopard suggest, there is an increase in arrhythmias, so they said not to use levosimendan in ICUs. Let's discuss about respiratory support. For patients with sepsis and hypoxic respiratory failure, the guidelines clearly suggest using high-flow nasal cannula therapy compared to the conventional oxygen therapy in a patient with moderate ARDS with PF ratio less than 200. And they also suggest using HFNC over initial therapy compared to non-invasive ventilation. Compared to NIV mask and all those things, because as per the Florali trial, there was a superior patient comfort with HFNC and better compliance and no mask-related complications. And HFNC has shown to reduce overall ICU mortality also. And they clearly suggest not to combine HFNC and NIV compared to only using HFNC. They suggest using only HFNC. And for patient with mechanical ventilator with ARDS, the guidelines clearly suggest low tidal volume ventilator strategy, which is lung protective ventilation with low tidal volumes of 6 ml per kg compared to 10 ml and above. And for patient with non-ARDS, they suggest to go with a normal tidal volumes of 6 to 8 ml compared to lower tidal volumes. And for all the patients with ARDS, the guidelines clearly mention to maintain plateau pressures less than 30. And for patient with ARDS, as per the alveoli trial, the guidelines clearly mentioned to go with higher PEEP compared to the lower PEEP as per the mortality benefits are more. And for patient with severe ARDS, the guidelines recommend proning for at least 12 to 18 hours as per the ProSaver trial, which has shown significant improvement in the mortality. And even in COVID time, we have seen with mild ARDS patient also, awake proning has helped in improving oxygenation and in decreasing mortality. And in patient with ARDS who's on ventilator, these patients, we should use intermediate neuromuscular agents than giving continuous infusion of these drugs, which cause unnecessary complications. And patients with severe ARDS with refractory ARDS, the guidelines clearly mention to go with veno-venous ECMO. As per the landmark trial, Lexizar and Yulia, that has proven to reduce mortality by using early VV ECMO in a ECMO dedicated centers. The guidelines mention as per the adrenal trial, using IV hydrocortisone, especially the dose of 200 mg in 24-hour infusion, has shown good benefits in decreasing the vasopressor doses. And there is no role of vitamin C. It has caused more harms in that all the trials. No role of vitamin C, no role of immunoglobulins in septic shock. This guidelines is like a blood purification techniques. They used a lot like polymyxin B or cytosol hemofiltration. I have seen significant in my own practice. I have seen there's a good improvement within 12 to 18 hours after starting this cytosol filter in decreasing blood pressure supports. But the guidelines this time clearly mentioned that you should not use these blood purification methods. And there is no role of vitamin D in septic shock and sepsis. And this Chinese herbal medication, which has some promising results, which was approved in China, but is not advised as per the guidelines of sepsis and septic shock. They mentioned to use only in China, not in other countries. And for stress ulcer prophylaxis, the guidelines clearly mentioned for patients with sepsis and septic shock to use PPS as a stress ulcer prophylaxis. Even the 2026 guidelines also mentioned PPS are superior than H2 blockers in preventing upper GI bleed. There's no role of probiotics. And this is the common scenario that we see in all the ICUs. Initially, after recovery from the septic shock and after resuscitation, we'll flood the patient with excessive fluid. After the third day of the recovery, we see they get excessive fluid all over the body, and third spacing and pedal edema and pleural effusion. These patients, the guidelines suggest to use diuretics or ultrafiltration, depends on the requirement of the patients. And blood transfusion, the guidelines recommend using restrictive transfusion strategy compared to the liberal transfusion strategy. And start early nutrition within 72 hours of sepsis is always advisable. And insulin therapy when the sugars are on the higher side. And renal replacement therapy when there is no definitive indication for RRT, you should not use RRT in the ICUs. Whereas if there is a requirement for RRT or renal replacement therapy, they should think about going with CRRT or SLED kind of things when there is a septic shock is there. And there is no role of soda bicarbonate. They clearly mentioned against using soda bicarb therapy to improve hemodynamics or vasopressor requirements in sepsis-induced lactic acidosis. Whereas they mentioned again that in severe metabolic acidosis with acute kidney injury, they suggest using soda bicarb when the Aiken score of 2 or 3. And for DVT prophylaxis, they clearly mentioned using pharmacological DVT prophylaxis unless there is any contraindication. And they also mentioned about using only low molecular weight heparin as a choice compared to unfractionated heparin for DVT prophylaxis. And also they clearly mentioned using only heparin or pharmacological DVT prophylaxis compared to mixing both heparin plus SCDs. So use either one. When there is a contraindication for heparin or unfractionated heparin or low molecular weight heparin, then only you have to think about going to SCDs, sequential compressive devices. This time they clearly mentioned about discussing with the patients regarding the sepsis and septic shock, the prognosis and everything to the family early. Within 72 hours, we should counsel the patient about the disease condition and the outcome and the treatment goals. Because the mortality is so much high, so you should counsel the patient early about the clinical condition when somebody lands in sepsis. And they also clearly mentioned patients when transition of case, like from shifting from ICU to the wards, they should use proper critical care transition programs. And they also clearly mentioned about using handoff process for all the critical ill patients when you transfer the patient from ICUs to the ward. And even while transferring the patient, even while discharging the patient, we should use the medical reconciliation form, which should be used by the pharmacist and also the duty doctors and nurses to avoid any mistakes in the drugs. A few more slides. This time the emphasis about the post-sepsis care, especially about the family education. A lot of people in the world knows about the COVID and other things, but nobody knows about the sepsis. You should clearly, whenever the patient comes, you should guide them about the sepsis, the outcome and the complications and the prognosis and the mortality, everything. You should educate the patient about sepsis when they come to you. Even before the discharge or after the discharge also, you should educate them, because there are so much of comorbidities, morbidities that happens even post sepsis recovery also. There will be a lot of complications for the patients. So post-discharge care, they emphasize more this time for the post-critical illness follow-up services, especially look for physical, cognitive, and emotional problems after the hospital discharge. And always assess them for the mental health after the hospital discharge. And if somebody is having the problem, refer them to the psychiatrist or the concerned doctors. For patients who are ventilated for more than 48 hours, the guidelines this time mentioned clearly to go with physical rehabilitation service after hospital discharge. In summary, I want you to understand that sepsis is a medical emergency. So the first 1 hour bundle, collect the lactates, blood cultures, and start early antibiotic when there is a sepsis or septic shock. Give fluids when there is a shock, and start early vasopressors if it is necessary, and target MAP around 65. These are the guidelines. Thank you for your patient listening. And thank you all the nurses for your support, and happy Nurses Day to the nurses.